Right, thank you. Can you hear me?
Yes, we can hear you and we can see your slides.
Okay, right. So my talk is about hypertension in children, which is quite a big topic, but I'm just going to do as much as I can, but not everything. I'm just trying to get this thing to move up. Right, so I think the main thing with hypertension is still you need to actually measure it properly. And otherwise, you won't believe how many times we actually cure hypertension by just measuring it properly in the clinic. And in our situation, I think it's the manual blood pressure for children, unless you're an infant, is still the best way of doing it. The problem is that you actually, we're running out of mercury sphygmomanometers because they're banned. And as they give up the ghost, they're being taken away from the clinic. So that's a bit of a problem. But you can use an aneroid blood pressure measure as well. The problem with aneroid blood pressure measurements is they actually need to be calibrated as well, probably every 6 months to a year, which I think probably doesn't happen in most places. But anyway, you should do it remember, the patient must be seated for a few minutes. You be at the level of the heart, so that the arm does actually have to be lifted up slightly. Inflated to 20-30 millimeters above the systolic blood pressure, and then the systolic is when it disappears. When it's first heard, and then when it disappears, not when it gets soft, is the diastolic. And then remember the cuff size is very important. It's probably better to have a slightly bigger cuff than a smaller cuff. The bladder of the cuff needs to go 90% around the circumference of the arm. And then there's the guideline saying the width needs to be 50% of the arm circumference, but basically they only come in a few sizes. So the blood pressure cuff should fit snugly in the upper arm. And then you need to measure 2 to 3 times per visit for at least 3 visits to say it's actually high. And yeah, as I said, big is better than small. Oscillometric devices. So we have a lot of oscillometric devices in the hospital. What they actually do is they measure the mean and then calculate the systolic and diastolic blood pressure from this. And they have been shown to be consistently higher on a Dynamap than measured manually. And also, you need to do it actually a few times because the Dynamap often reads high the first time and the second time, and then it starts going down. And after the fourth reading, it sort of levels out. So you need to do it quite a few times. They're also supposed to be calibrated yearly. And in fact, there only are 2 Dynamaps that are recommended in children. And most people haven't actually got them. But they're good for neonates and for infants in ICU, and they're good for screening. So it's definitely better than no blood pressure. But if you get a high Dynamap reading, you need to confirm it by auscultation. So ambulatory blood pressure monitoring in high-income countries is becoming more and more the gold standard. We actually have got an ambulatory blood pressure monitor, but we tend to use it in specific patients. So we'll often use it when we suspect there's white coat hypertension. In other words, a child has got a high blood pressure at the clinic, but not at home. And you can usually spot these children because they're terrified and they often tachycardic. Masked hypertension, also other indications of masked hypertension I'll get to in a minute. And then also severe obesity with or without sleep disordered breathing. And then if there's symptoms of hypotension that you want to try and catch episodes of hypertension, and these are more rare things, or catecholamine or autonomic dysfunction, also indications which we have occasionally used it for. But it takes quite a lot of PT, and you need sort of to be organized. And, we certainly can't do it on every single patient that comes to our clinic with high blood pressure. In infants, it's difficult. We still use auscultation a lot of the time. You can use a Doppler. You get these old Doppler devices, and we used to have one. Remember, Mignon brought one back from England, and we used it for quite a bit. It went missing. And then obviously oscillometric devices or palpation as well, if you can't feel it. So you actually just feel for the blood pressure, and you can just get an idea about when the systolic is. And then neonates are notoriously difficult because if they're screaming or if they're drinking, then the high blood pressure doesn't count. And there's actually a standardized way of measuring it in neonates. So this is in NICU setting. It's supposed to be 1.5 hours after feed or medical intervention. So, you've got to choose your time right. And then they need to be undisturbed for 15 minutes. So you put the cuff on and leave them for a while, and then need to be in a sleep or in a quiet environment. So quite hard to actually get the right moment to do this. If you see a neonate screaming his head off, the blood pressure is definitely going to be high. Okay, now let's talk about white coat hypertension. So this is a type of hypertension that's where children actually have a high blood pressure, and you can see it often, as I said, they're tachycardic and they look scared. It actually needs following up, and if you suspect it, then this is when ambulatory blood pressure monitoring is actually quite a good thing. So masked hypertension, strange hypertension, is that when you do it in the office situation, it's normal, but it's at home, and you might say, well, how do you know it's high at home? So you might pick up target organ damage, but children with chronic kidney disease and children with diabetes are actually at risk for masked hypertension, and so guidelines actually suggest that you do screening on all these patients with ambulatory blood pressure monitoring, but I mean, there's no ways that we can actually do screening on every patient with chronic kidney disease in our clinic with ambulatory blood pressure monitoring. So we don't actually do screening for this group of patients, which we would like to do. And obviously in the future, maybe we could do that. If you see a systolic in adolescence, if you see patients with a systolic blood pressure, which is above the 90th percentile, but the diastolic is less than the 90, that is quite a common finding. Not very common, but it's because of difference in compliance of upper limb vessels in adolescence. And unless there's target organ damage, you can actually just monitor this and just keep an eye on it. Just remember, the blood pressure varies over 24 hours. It's low in sleep, it's high in wakefulness, and it peaks in the morning and another in the late afternoon, and it changes with temperature a little bit as well, and with posture and activity like exercise. So it's quite normal to have a high blood pressure value during exercise, and there actually are percentile charts for blood pressure during exercise. So you can go, you look at it like the 90th centile for a 15-year-old with high intensity exercise goes right up to 180. So just to talk a bit about, so adults, hypertension in adults is a very problem. I mean, it's one of the major sort of burdens of disease in adults. And the hypertension they get is usually primary hypertension, and it accounts for 13% of adult deaths annually. And almost half the adult population in South Africa has hypertension. So in adults, we actually, that's why it's recommended that you do your blood pressure every year so that you actually screen for hypertension, because it can creep up on you without you knowing it. But what is pediatric hypertension? So pediatric hypertension isn't based on outcomes. So in adults, the cutoffs that are given for adult hypertension are based on morbidity and mortality outcomes. But pediatrics are not based on outcomes. Basically, they're based on the normal population. So anything above the 95th percentile is considered high. And you've probably seen all these. These are the centile charts, and they're based on your height and your sex, and so anything above the 95th centile is hypertension. Of course, there's also different charts for if you are from 1 month to a year. So these are 1987 guidelines. These are the only ones that still exist for this age group, from 1 month to 1 year, and this is the reference for that. And then also for neonates, and this is an article where you can find neonates for post-conceptual age for neonates. So basically, you've got one for neonates, and you've got one from 1 month to 1 year, and then you've got the other centile charts. And then, of course, also for ambulatory blood pressure, there's also different centile charts. And so just remember that you can't use the centile charts for office blood pressure for ambulatory blood pressure, but actually these are built into the machine, so you can they will actually do this for you into the software of the ambulatory blood pressure machine. The problem is also that every population is actually different, and there's no normative reference values for South African children. And there's actually a greater susceptibility to hypertension and target organ damage observed in younger people of African ancestry. And obviously, there's very different socioeconomic environments compared to what the normal blood pressures, which were mainly measured on white children from North American or Northern Hemisphere countries. So when you say it's hypertension, basically, this is from the European guidelines, which are, I think, are quite nice. You measure the systolic and diastolic blood pressure. If you're above 16 years of age, then you use the adult cutoffs. So anything that's less than the 90th centile or less than 130/85 is normotension. If it's above the 90th or 130/85, if you're more than 16, then you do repeated measurements. And if it is less than the 90th centile, then it's normotension. If it's between 130 and 190, 130 to 140 or 85 to 90 diastolic, that is high normal in children above 16 years of age, or anything from the 90 to 95th, and you need to do repeated measurements to watch these children. If you're above the 95th centile, then it's hypertension, and you need to evaluate for etiology and organ damage. Anything above 140/90 in children above 16 years of age. So then hypertension, as I said, is further to stage 1 hypertension is generally asymptomatic. Sorry, this is actually, I think, incorrect. So it's above the 95th centile. Stage 2 hypertension is anything above the 99th centile plus 5 millimeters of mercury. And that's kind of like, well, severe hypertension, and it's usually symptomatic. And the problem is the stage 1 hypertension is often asymptomatic and will be picked up on screening or on seeing the doctor who does blood pressure measurement. Or maybe you need to do it on 3 separate occasions to actually diagnose hypertension. So at Red Cross, we actually spend most of our time diagnosing and treating causes of secondary hypertension or managing severe hypertension. That's kind of what we end up doing. So we will be doing things like MRBG scans to look for pheochromatoptomas, or maybe eventually doing angiograms. And you can see on this angiogram, there's a left renal artery stenosis. So, you need to have a systematic way of looking for hypertension if you find it, of looking for causes of hypertension. And if you've got a small child, then it's more likely to be secondary hypertension. And you need to keep actually looking until you've almost exhausted all the investigations. But it's kind of better to do them in a stepwise approach, so you don't throw every single investigation at every child. So we generally do it in a stepwise approach and to try and get the diagnosis. But talking about primary and secondary hypertension, so we looked at our data from 20 years, and in the first 10 years from 2000, basically we had only primary hypertension in about 7.5% of children. In the second decade, from 2010 to 2020, it's gone up to 35%. So the actually increasing amount of primary hypertension we're seeing is getting more and more. But 45% of children with primary hypertension were actually obese. So it probably is following the obesity epidemic for one thing, but it's also following screening and the fact that people are doing blood pressures more often, because these patients are usually asymptomatic. So unless you actually measure the blood pressure, you'll never know. So I think screening and the fact that there's children who are obese are then getting their blood pressure measured, you find that they've got a hypertension. If you look at data from North America, this is 1988, they also had a very low, the black is primary hypertension, very low percentage of primary hypertension. And as it's gone on to, this is only to 2010, and I'm sure it's more now, you can see it's up to 90% of the patients in the clinic are actually primary hypertension. And of these patients, these are the body mass index of the patients with primary hypertension. Most of them were well over the 90th centile for the body mass index. So definitely something to do with obesity, but also to do with screening. This is a study from South Africa, 162 healthy children, aged 5 to 9 years. 20% of these children were obese or overweight. 14% had hypertension, so more than 5%, which is more than 90th percentile. And then there was a 51 to 60% increased risk of hypertension for every 1 standard deviation of increase in body mass index. So again, showing it's the same problem we've got in South Africa. we're seeing at Red Cross and also around the country. If you've got primary hypertension, they're more likely to be obese with a family history of hypertension, mostly post-pubertal stage 1 hypertension. So if you see patients like this in your clinic, then you probably don't need to go down every single diagnostic avenue. You can probably diagnose primary hypertension. So the thing about primary hypertension is it seems to be getting more and more and more. And in adults, we do screening for hypertension. So should we be doing screening in children? And to answer this question, you need to ask yourself, is childhood blood pressure measurement associated with adult cardiovascular disease? And is treatment of high blood pressure in children associated with a reduced burden of adult cardiovascular disease? And you can't actually answer these questions directly because you can't do randomized controlled trials like this. But there are surrogate markers for cardiovascular disease in children. So recent multicenter cross-sectional studies show there's association with childhood hypertension and less left ventricular mass index. And longitudinal cohort studies showed that blood pressure levels in childhood are associated with increased adult cortico-intermediate thickness, which is a sign of hypertension, or stiffer blood vessels, narrowed retinal arteries, and left ventricular hypertrophy. So there's definitely surrogate markers showing that children with high blood pressure probably going to have adult high blood pressure and have a higher risk of cardiovascular disease. In the Johannesburg birth to 20 cohort from Soweto, 1 in 5 children aged 5 years was hypertensive, and 60% of them had high adult blood pressures. And blood pressure was shown to be associated with socioeconomic status and accelerated growth in infancy and childhood. And basically what they showed also is that there's an upward socioeconomic status change had a protective effect on systolic blood pressure by the time of participants reach adulthood. So we've definitely got a problem, and it's probably not diagnosed. So these are the Pediatric Association screening protocols in North America. They suggest that all children over 3 years of age should have their blood pressure checked at least once during each healthcare episode to screen for hypertension. And I think that's pretty good advice. And if there's a risk factor like low birth weight or CKD or UTIs, you probably need to do it before that as well. So after what I said, you say we start screening for hypertension. We should, right? Yeah. Well, maybe it's not that easy. The problem with screening is it's difficult, especially in low-income countries. You need the height and the age and the sex-specific centile-specific details of a patient when they're at the clinic. It needs to be confirmed on high blood pressure on 3 separate visits. You need validated oscillometric device that is calibrated yearly, or you need mercury devices, which are now banned, or you need an anaerobe sphygmomanometer, which needs yearly calibrating. So that's just not that easy. And also, if you think about it, if hypertension is defined as anything more than the 95th percentile, then 5% of children will have hypertension. And so where are they all going to be seen? I mean, certainly not in the renal clinic. It's like 1 million children in South Africa. So it's a big problem, and I'm not quite sure how we're going to face it. There was actually a study done from the US Preventative Services Task Force in 2020, looking at the evidence for screening in children, blood pressure screening. And they said they found 20 observational studies suggested significant association with childhood hypertension and abnormal blood pressure in adulthood, but there was no studies evaluating the benefits or harms of screening. And basically what they came to the conclusion was that observational studies indicating an association between hypertension in childhood and hypertension in adulthood. However, the evidence is inconclusive whether diagnostic accuracy of blood pressure measurement is adequate for screening asymptomatic children and adolescents in primary care. So this is still lots. So I think the conclusion is that hypertension in childhood needs detection and management to prevent end organ damage in children. But we still need to do studies on risk-benefit analysis and cost-effectiveness of actual screening. And we need to know the method and measurement of blood pressure. And we also need to have our own centile charts before we can start doing it. So if you've got someone with hypertension, the initial goals, you need to identify cause of secondary hypertension. As I said, I'm not going to go through all the different investigations, but you need a good clinical examination and a history, and quite detailed, because there are quite a lot of causes of secondary hypertension, and they're all quite rare. So you need to go into quite with detail and careful clinical examination to actually find them. You also need to identify other comorbid risk factors for cardiovascular disease, like obesity or dyslipidemia, and you decide who's going to be treated with medication. If you've got chronic hypertension, conservative measures are for all patients, and pharmacological agents are for symptomatic hypertension, or so stage 2 hypertension, or generally secondary hypertension, or if there's target organ damage, or diabetes, or to persistent hypertension despite non-pharmacological measures. So these are the patients who you'll initially give treatment to straight away with pharmacological agents. But if you have stage 1 hypertension, then you can first try conservative measures, so weight loss, diet rich in fruit, vegetables, and salt. So that 1.5 grams of sodium is about half a teaspoon of salt a day. So that's not a lot. And then exercise is very important, both aerobic and anaerobic, but probably more aerobic exercise. And you need to reduce cardiovascular risks, as I said, by looking at obesity and smoking and lipids. And the target BP is, you want to get to something less than the 95th centile. In certain groups of patients, you want to get something less than the 90th centile. So if they have other cardiovascular risks, evidence of a target organ damage, or diseases with higher risks of atherosclerosis. For patients with CKD, they even suggest that you get the BP below the 50th centile, which is quite tricky. These are acceptable drugs. We use a lot of calcium channel blockers because they're quite safe, especially when you don't know what the cause of the hypertension is. But then otherwise, we use a lot of ACE inhibitors, and then diuretics. ARBs are a little bit more expensive, so we tend to not use them as much, and beta blockers I prefer not to use because of the side effects. But generally what you need to do is start low, start with one drug, and then when you reach the maximum of that drug, then you can add another thing. If you're using a vasodilators, then a diuretic makes sense to add a diuretic, but you need to tailor it for the condition. So if you've got diabetes, ACE inhibitors, etc. And then you use ongoing monitoring for end organ damage, cardiovascular risk, electrolytes, and underlying condition.